Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the Ministry of Health and the Saudi Society for Clinical Pharmacy for inviting me in this great event that I hope, inshallah, will change the face of medical practice for better prosperity of our community. So what I'll be discussing today, of course, this is the first talk in a series of talks going to be followed. So I'll be putting the basis for hyperlipidemia. So we'll be talking about source of lipids in fasting and non-fasting state. How long do we need to fast for a test? When do we need to screen earlier? And the lipid profile and the growth in the fasting state. Then I'll be talking about diagnosis of primary hyperlipidemia in emphasis on familial hypercholesterolemia, in diagnosis of secondary hyperlipidemia and the underlying causes. So again, as an original biochemist, I have to start with lipoprotein metabolism in short. I'm very sorry. So as you all know, that the source of lipid in the blood comes from endogenous and exogenous source. The exogenous source contributes only to 15%. So this is a very important key information. In 75% comes from endogenous source, i.e. the liver. So keeping that in mind, it means the main contributing factor for lipidemia is the liver. And of course, the genetic background that shapes the level of lipid in the blood. So as you can see, and the exogenous source, after we eat our meal, all the cargo is packaged in high or very large molecules called chylomicrons. Those chylomicrons now are further hydrolyzed through the enzyme lipoprotein lipase, and all the free fatty acid will go into the tissue for use and storage. Then the remnant goes back to the liver through the LDL receptor. This is the exogenous pathway. So in the endogenous pathway, so this is the background of all the lipid source in the body. It comes from the liver. So all the cargo is packaged in VLDL, or very low density lipoprotein. Then it goes through the same enzyme, lipoprotein lipase, hydrolyzed. All the free fatty acid goes to the tissue, either for energy or storage. And then the size will be reduced to ILDL. And this ILDL, or intermediate density lipoprotein, will go directly to the liver, or is catabolized further as LDL. And then the LDL will go either to tissue or back to the liver. So this is the full cycle. So how long do we need to fast the patient for a lipid profile? So the ideal fasting interval is between 10 to 12 hours in order to get rid of all the exogenous sources of the lipid. So if you fast the patient less than this, you have triglyceride overestimation and LDL cholesterol underestimation. And if you fast the patient further or more, interval. But do you really need to fast the patient? This is a very important question in terms of, in diagnosis of hyperlipidemia, because it turns out that you actually don't need to fast the patient. For initial liver profile, you can screen with a non-fasting. For assessment of cardiovascular disease, in children, in diabetic patient, and patient on stable drug. So when do you need to fast the patient actually? You only need to fast the patient if you actually have an abnormal lipid profile. You have a non-fasting triglyceride over 5 millimole per liter. If you have actually a pancreatitis and you are trying to control the triglyceride, and if you have a medication that causes hypertriglyceridemia and you want to stable or you want to initiate a baseline. The other question, when do you need to screen for hyperlipidemia? In the previous consensus guidelines in 2016, we advocate to screen the patient, every patient or every individual above 20 years. If it's normal, then you repeat every 5 years. And actually in our new Saudi guidelines, we did the same. We advocate to screen all of the individuals above 20 and rescreen every 5 years if it's normal. However, you can screen earlier in certain individuals who are diabetic, have hypertension, and central obesity in patients with systemic inflammation and offspring of patient or families of primary dyslipidemia. So those are a high risk. Therefore, you need to screen before the age of 20. Now moving on to our tool that we diagnose hyperlipidemia with. So we have our standard lipid profile that is constituted of total cholesterol, HDL, and triglyceride. So this is all direct measurement. However, your LDL cholesterol is calculated from your total cholesterol, triglyceride, and HDL. And we advocate to also calculate non-HDL. So this is either also in our study guidelines. Those are the basic or the main, let's say, hallmark of treatment of hyperlipidemia. So non-HDL is a very simple equation, which is total cholesterol minus HDL. So it doesn't really, in terms of value, it doesn't really cost anything. It's just a simple calculation that the lab performs and give it to you in the same lipid profile. You can also calculate something called remnant cholesterol, which also is an additional information. It represents something called residual risk. So if you have a normal lipid profile and this is abnormal, then you might have more or an additional risk. In the lipid clinic, we do extra testing. We rely on high-sensitivity reactive protein in order to diagnose subendothelial inflammation. We do ApoB, which is a direct measurement of all atherogenic particles. We also measure Lp(a). This is the most atherogenic particle of the LDL subclasses. We can also do specialized testing like homocysteine, which is an independent risk factor, particle size, and ApoE genotype. So this is your classification of hyperlipidemia. So hyperlipidemia is either hypercholesterolemia or hypertriglyceridemia. So if you have anything above 5.7, so this is actually the main cutoffs that we have to alarm our physician to. So anything above 5.7 non-HDL, which correspond to 120 milligram per deciliter, is very high values, or an LDL above 4.9, which correspond to 190 milligram per deciliter. So this is all diagnosis of primary hypercholesterolemia. And if you have a total cholesterol, triglyceride above 5.6, which correspond to 500 milligram per deciliter, this is very high, and this corresponds to primary hypercholesterolemia. So hyperlipidemia, again, either is primary or secondary. Primary hyperlipidemia is mainly due to genetic cause, example, familial hypercholesterolemia or familial hypertriglyceridemia. And actually, the diagnosis of hyperlipidemia starts from the blood sample. Just drawing the blood from the patient and keeping it in the refrigerator for 18 hours, you would have something close to this. So if you have a type 1 hyperlipidemia, so this is familial hyperchylomicronemia, you have a creamy layer on the top. So this is very pathognomic and very simple. You haven't even done the assay and you have diagnosed the patient. Familial hypercholesterolemia, they have a very normal actually serum because they only have isolated LDL cholesterol. While the other times they have a turbid to a creamy layer. So this is actually the way Fredrickson classification has started. So type 1, as we said, is actually due to a mutation or null gene in the LP lipoprotein lipase. Familial hypercholesterolemia is either one of the mutation in the LDL receptor or ApoB, the ligand, or PCSK9. And type 3 is a mutation or a variant in ApoE2. So this is where the mutation in the hypertriglyceridemia is usually either mutation in the lipoprotein lipase or there is coenzyme ApoA2. The LD receptor is mutation in the receptor, which causes familial hypercholesterolemia. And if you have a variant in ApoE2, you have something called beta lipoproteinemia. So familial hypercholesterolemia is due to, it has a very broad spectrum, basically because we have 3 main genes and we have different heterozygosity or different combination of mutation. So if you have 1 mutation, it's different from having 2 mutations, and the degree of mutation matters. So heterozygous usually starts, the LDL starts from 5 millimole per liter or 190 milligram per deciliter. Homozygous, you will see patient more often coming with an LDL of 13 mole per liter or more than 500 milligram per deciliter. So just to make sure everyone is on track, let me pose a question. What is the prevalence of heterozygous familial hypercholesterolemia? And with a show of hand, is it in the GCC, of course, is it 1 in a million? Any takers? Is it 1 in a quarter of a million? Anyone? Is it 1 in 500? Wow. Usually I'd have 1 at least raising his hand. Now there's only 1. Usually I have more than 1. Is it 1 in 250? So this is the globally now. We have moved from 1 in 500 to 1 in 250. However, in the last FH registry in the Gulf, it was 1 in 112 in a hospital setting. So this is huge. It means if you have a busy clinic and you see at least 20 patients a day, you would at least encounter 1 FH, at least. Of course, if you have a lipid clinic, you will see every day, at least 10 patients. So again, just a pattern recognition. This is a very classical presentation of an individual who had initially an LDL of 5.5. He is unfortunately treated with a statin, a very, a standard monotherapy approach. He develops, so his LDL drops from 5.5 to 4. He developed an MI at the age of 24. Nothing drastic happens. 4 years later, 2 years later, he developed another MI. Now the physician put him on combination therapy, rosuvastatin and ezetimibe, and the LDL falls to 3. Of course, in any guidelines, this is not optimal. So what happens? The patient continued to develop atherosclerosis. At the end of the day, he required coronary bypass grafting and aortic valve replacement at the age of 33. So again, we're just looking at this pattern, you would quickly diagnose an homozygous, at least heterozygous, severe heterozygous or homozygous individual. What would more make you reassure that if you have signs of dyslipidemia? So if you don't look for signs of dyslipidemia, you miss them. You have to, you get your eye practice on looking for them. So it's either xanthelasma around the eyes, corneal arcus, especially if in the age before 45. Of course, a hand and leg and feet, you will look for tendon and external xanthomata. So to diagnose familial hypercholesterolemia, you have to rule secondary causes by just doing a simple, a panel of tests. Usually treating the underlying cause, the dyslipidemia will disappear. In primary dyslipidemia, of course, you don't have any underlying cause. You would see the abnormal isolated LDL pattern. You rarely see signs of dyslipidemia, but you have a very significant family history of premature coronary disease. To further confirm your diagnosis, you should do in a certain set of criteria. You will either do a Dutch Lipid Clinic Network score or Simon Broom diagnostic criteria, or MedPIT, and they're all available online as calculators. However, the gold standard remains to be a genetic testing. Once you have confirmed the diagnosis, please document it in the file. Because without documenting it, nothing will happen. Because once you diagnose an FH, you have opened the door for a whole family, maybe a whole tribe that has dyslipidemia. And please, nowadays, we have to not only document it, but put at least the ICD code 10, which is E78.01. So this is the code for familial hypercholesterolemia. So our patient, if you do the Dutch Lipid Clinic Network, he has a premature coronary disease, so he deserves 2 points here. He has a corneal arcus with less than 45 of years, so this is 4 points, and his LDL was 5.5, the baseline. So this is another additional 3 points. So in total, he has 9. So this is definite FH. So after diagnosing the patient, you should put the patient on at least combination therapy in order to reduce and bring the LDL down. Now, the whole really population management and family screening has to take off. The patient at least has to do 1 Lp(a) test. Imaging will help a lot of putting a patient how fast and how strong your intervention. And lifestyle in this case is not very effective. We still advise lifestyle modification, but as a genetic disease, it's driven by your genetic background in your liver. So nothing will happen if you fast or do exercise. Actually, those patients are very athletic and they're very thin. So there's nothing much to be done there. But the most important lifestyle modification here is smoking cessation. Because I always tell the patient, if you have a genetic gun, you have another gun if you smoke. So you have actually, double effect. Again, this is just an advertisement for the Saudi guideline for dyslipidemia, and Dr. Jamila will be spending more time discussing it. However, our guidelines put a lot of emphasis on genetic dyslipidemia or hyperlipidemia. As you can see, if you diagnose someone with FH, he's already high risk without an event. If you have an event, now he's a very high risk. And if you have a recurrent event, now he's extremely high risk and his LDL should be lowered very significantly. If you don't do so, the patient will progress and you will have aortic valve stenosis, calcification. Actually, the whole aorta from the bivalve, from the aortic valve until the end of the aortic the wall is completely calcified. So this is a significant atherosclerosis that it implies a lot of comorbidities. So now moving from primary hyperlipidemia to secondary hyperlipidemia. In primary, we said there might be isolated hypercholesterolemia or isolated hypertriglyceridemia or mixed. In secondary, usually they are mixed hyperlipidemia. And usually it's due to the underlying cause, whether diabetic, nephrotic syndrome, liver disease, in particular obstructive liver disease, hypothyroid, or any offending drug. Diagnosis of hyperlipidemia in secondary, again, as we said, is mixed, but it has a pattern. If you have metabolic syndrome, diabetes, you would see the triad of high triglyceride, high LDL, and low HDL. So this is very common. If it's due to alcohol, you will see high triglyceride and high HDL. If you have hypothyroid, nephrotic syndrome, chronic renal disease, or any offending drug, you would see a mixture of either more of an LDL or more of a triglyceride. So I will have to concentrate on metabolic syndrome. When you see a patient, you have to do waist circumference. As we said, we have a high prevalence of obesity, diabetes, and all it starts from visceral obesity. So if your waist circumference is abnormal, then you will start the whole journey of cardiovascular morbidity. You will start to exhibit hypertriglyceridemia. You have a low HDL. You have high apolipoprotein. And you have small, dense LDL. So the small, dense LDL is a more atherogenic particle, and it contributes to high cardiovascular risk. So doing a lipid profile in someone with visceral obesity or metabolic syndrome, there's a caveat. Your LDL might be normal, but this is a false normal LDL. The thing that will give away a normal LDL here, or a not very striking LDL, is your triglyceride. If your triglyceride is 1.7 above 1.7 millimole per liter, or 150 milligram per deciliter, then your LDL is not the normal, buoyant LDL. No, it's a more dense, small, atherogenic LDL. And here, your LDL shouldn't be your target. Your target should be your non-HDL or directly the ApoB. Why is the metabolic syndrome? I would say that this is the key for all diseases, because you start to have insulin resistance. With insulin resistance, you have hyperinsulinemia, glucose intolerance, hypertriglyceridemia, and then the whole pro-inflammation, pro-thrombotic, pro-hypertensive status begin with all of the cytokines that are poured in the circulation. And this would lead to, in the end, to ectopic fat deposition around the heart, around the vessels, around the major organs. And of course, you will get, disease everywhere. You will have pulmonary disease, non-alcoholic fatty liver disease. You get osteoarthritis. You have a stroke. You are at the risk of coronary heart disease. You probably have higher triglyceride. Some cases we've seen even pancreatitis, and you will have a high risk of cardiovascular cancer. And this is actually my last slide. And I'll be happy to answer any question. Just to conclude or to summarize, the source of lipid in our body is mainly driven by genetic, because the whole bulk of lipid in the blood comes from the liver. Non-fasting is actually a very useful approach, and you have to repeat an abnormal lipid profile with a fasting sample, and the duration here matters. So you have to respect the interval in order to not overestimate or underestimate. A general population screening is very useful. Any individual above age of 20 should have a lipid profile. If it's abnormal, if it's normal, you repeat it in 5 years. If it's abnormal, then you do a fasting lipid profile to look for hyperlipidemia. Primary hyperlipidemia, isolated hypercholesterolemia, it mainly is from familial hypercholesterolemia, giving the high prevalence. Isolated hypertriglyceridemia is usually also present in pediatric. I'm sure Dr. Muhammad will be speaking more about it. And in secondary hyperlipidemia is usually due to another disease, underlying disease. Once you treat the underlying disease, the hyperlipidemia goes away. And mainly I will emphasize on metabolic syndrome, obesity, and diabetes. And thank you very much for your attention.